Welcome, everybody, and thanks for taking some of your time for our inaugural CELA Speaks lecture and discussion series. I think tonight it might be a little more of a lecture than a discussion, but I'll try to save room at the end. I apologize. This lecture is probably going to be longer than I originally thought it was going to be. It's such an interesting topic. I hope we will all find it interesting. Also, we have to give credit to our CELA Vice President or President-elect, Jan McAllister, for coming up with the name CELA Speaks. I think it's a pretty it's a pretty terrific name, and hopefully we will continue to do this every month or so from here on. The first slide I wanted to go to, and let me make sure I get this in presentation mode. There we go. I wanted to mention some initiatives that I have set out for to try to accomplish during my year of presidency. And that is, I'm very interested in some tear sheets on specific topics. I have listed here the board members and their emails, and I apologize if I have misspelled anybody's name. The board members and the emails that are working on these different tear sheets. I hope some of you will be interested and email me and or the board member working on this particular project. I want to build off tonight's presentation and have both a clinician and a patient tear sheet about NASH, NAFLD, diagnosis and treatment. One of my core things that I do and promote in my patients is resistance training. A lot of our patients walk or do aerobic exercise, but only a minority are doing true resistance training. And I think that's very, very important. So I want to try to develop a tear sheet about that. Seth Martin and Mary Catherine Chile were interested in my thoughts about trying to leverage social media a bit. We do have a Facebook page for CELA, and maybe we can increase membership and participation through social media. Jan has been really helping out a lot with the CELA Nights, or CELA Speaks, we should say, initiative kicking off tonight. Membership retention, Kathy Byrne was interested in helping out with that, and I have the names and email addresses for the other board members down here. This slide will be made available to you later, so we will get it out through Kathy and the NLA. I want to remind everybody about the Aim for Atlanta Pentathlon Challenge, which is kicked off. You can earn various points different ways. We certainly want to come out number one, CELA, so I hope everybody will participate in these activities. Here's a list of the January challenges, including tonight's CELA Speaks lecture. So let's wade into it. Starting off with some pearls for diagnosis and treatment of NASH, NAFLD. You might notice on my first slide, I called this MAFLD, and I kind of like that name better. And it's starting to gather acceptance. MAFLD would stand for metabolic associated fatty liver disease. That's one of our themes tonight, that this is all interrelated with insulin resistance, cardiovascular risk, liver disease, and kidney disease. So NAFLD is defined as greater than 5% liver steatosis without evidence of hepatocellular injury. NASH is the same thing with evidence of hepatocellular injury, and you would see this on biopsy, for example, with ballooning plus or minus fibrosis. Most of the old salts around know that an AST to ALT ratio is usually greater than 2 in alcohol-related disease. So that's a quick way of assessing maybe what's causing the fatty liver. If you just look at random diabetic patients attending an endocrinology clinic, 70% of them, 70% have MAFLD, and 20% of them have fibrosis. And most of us aren't aware of this. We're not screening for it. We're not targeting therapy towards it. As we will see, a lot of our typical diabetic therapies are going to have very positive effects on slowing the progression of MAFLD. But there are some specific things that we can do for MAFLD. So our number one strategy for risk assessment is to rule out advanced fibrosis. And it's been a journey to develop good non-invasive scoring techniques to assess the risk for fibrosis. We don't want to have to do liver biopsies on everybody, or preferably not on anybody. But we're going to talk a lot about the FIB-4 calculator and the FIB-4 test, which is readily available, inexpensive. Hopefully some of you have ordered it. Hopefully after this lecture, a lot more of you will order it. It's actually available online at this link. So management, the number one priority is decreasing insulin resistance. That's the straw that's stirring the drink here of the fatty liver, so to speak. And the magnitude of the weight loss really correlates with improvement in the liver histology. For those that think this is a problem that's difficult to solve, even 48 hours of a low carb, low cal diet can decrease your intrahepatic triglycerides by 20%. 7% weight loss can decrease your intrahepatic triglycerides by 40%. Exercise is much less effective, but still an important part of our strategy to reduce insulin resistance. You have to get more weight loss to decrease fibrosis once it's there. So another reason to try to catch this NAFLD epidemic early. So here's a case study. A 53-year-old woman with diabetes. Overall, she's healthy except for the diabetes and hypertension. Family history is positive for diabetes. Mother has a history of quote-unquote liver disease. She's got some right upper quadrant discomfort, and that's really not common in this disorder, but it's in here in this example. Exam was normal except for her BMI, which is in the obesity range. Fasting blood sugar was 187. Hemoglobin A1C is 9. You can see her liver function tests are definitely elevated. And, when we talk about elevations of liver function tests, remember that our labs, typically my lab, typically says up to 40 is considered normal. But most experts in this field would say that you need to start thinking about fatty liver when the liver function tests are over 30. Remember, that's just a bell-shaped curve when the lab tells you what's quote-unquote normal. Remember, the American public isn't very healthy these days. So the definition of normal based on the lab data is not really what's normal for a human, because a lot of us don't have a normal human physiology anymore, at least not a hunter-gatherer physiology. You can see the albumins at the lower end of the range, platelets at the lower end of the range. What should we do next? What kind of blood test should we do? What kind of, should we do a liver ultrasound? Does this patient have NAFLD? Do they have NASH? Do they have fibrosis? What are we going to do as primary care providers? And that's one of my main themes I want to hit tonight, is that we at the NLA as lipidologists are really uniquely positioned for this kind of cardiometabolic risk reduction strategy. I think the NLA is getting more and more into this, and I think we really ought to seize this, because other groups are starting to seize cardiometabolic risk reduction as their own, like the obesity certification boards, et cetera. So not all these patients need to be referred to a hepatologist. You can do most of this yourself. And we're doing a lot of it here at the Baltimore Lipid Center. And I hope to encourage most of you to do the same. So we want to shift our mindset as primary care and endocrinology physicians to focus beyond looking at the ALT and the AST. You want to calculate the FIB4, which we'll come to and cover extensively, and you want to consider doing something like liver elastography. The most commonly used type is called the FibroScan. That's a branded name. A lot of us are getting abdominal ultrasounds for other reasons, or we toss it in when we do our advanced carotid and femoral plaque imaging. So we're looking at livers a lot through different techniques. So the progression and prevalence of NAFLD, 1 in 3 of Americans have it now. And you can see what happens histologically when you get the early fatty liver stages. You can see these big droplets and the disordered architecture you see at the bottom of the slide from the lipid droplets. So I'm not going to do a lot of pathophysiology tonight because we don't have time, but basically the liver fat arises when you have an uptake of fatty acids and triglycerides from diet, and when you have abnormal lipogenesis, when these things overwhelm the ability of the liver to oxidize fatty acids and export them, then you're going to get fatty liver. It's a garbage in, less garbage out, kind of phenomena. The adipose tissue is a fat storage depot, obviously, but when its storage capacity is overwhelmed, then you get this increased influx of fatty acids, free fatty acids to the liver, and that's going to generate triglycerides and liver fat. And these disordered adipose tissues also promote hypoxia and oxidative stress. You get these pro-inflammatory cytokines and chemokines, and that leads to the further progression from fatty liver to NASH, and then even on further to fibrosis, as you can see on the right-hand part of the slide. Fructose is particularly, as we'll talk about later, fructose is particularly damaging to the liver. It's the most damaging of the sugars that we can consume. So risk factors are obesity, type 2 diabetes, metabolic syndrome. Early NAFLD is clinically silent. That's very important. As you said, 70% of our diabetics have it, and most of us don't even know that. Less than 10% of NAFLD is being diagnosed. It has its own ICD-10 code. I think it's K76.0. Liver biopsy is the official method to diagnose NASH, but there's lots of problems with liver biopsy. I haven't done one in years. Sometimes the hepatologist will do it, but you don't need it to manage 90% of these patients, probably more than 90%. Specialists previously lacked clear direction to treat this beyond lifestyle intervention, but this is really changing now that we have more effective mechanisms to facilitate weight loss in our patients. We're going to talk a lot about, to some extent, about GLP-1 agonists and their role later on. So it's not just about the liver function tests. People with diabetes are at risk of having a clinically significant fibrosis. But as we mentioned before, 70% of our diabetics already have NAFLD, and about 15% of them have significant fibrosis. And only less than a third of these patients would ever come up on your radar if you're just focusing on AST and ALT. So this is really not the approach that we need to use. Sure, we're gonna investigate unexplained AST and ALT, but we've got to look at the overall patient phenotype of insulin resistance, and we need to be more aware and start screening for NAFLD. So we're hoping that, now that we have this FIB-4 test, which is inexpensive and easy to get, that we're going to start getting a change here where we're going to start doing FIB-4 tests on our patients at an earlier stage in this process, diagnostic process. We're not going to wait and just do it in patients which have elevated LFTs. So what is this FIB-4 index? And I'm going to get something off my slide here. So these are slides from Quest. I don't mean to promote them, but they had the best slides for this, so they offer it. So the FIB-4 index is based on standard laboratory parameters: the patient's age, the AST, the ALT, and the platelet count. And you can see this complex calculus-like equation over here by which this is derived. You can get that calculator online, or there is an app you can have on your smartphone or your tablet, which I'll show you in a second, and I use it multiple times per day. So the real utility of this test is to rule out. It's got a very good negative predictive value. I think I have that coming up. No, I guess not. Has a really good negative predictive value for ruling out fibrosis, which is really what you want to find. Is fibrosis is really obviously the end stage, or one of the end stages, and the worst aspect of something like NAFLD or NASH. So the test is really good at ruling out fibrosis. So you get patients either in the green zone, which means that unlikely to have advanced fibrosis. Like I said, very high negative predictive value. You get intermediate results, and then you get advanced results, which indicate fibrosis. Here's the pop-up that I thought I had. So again, the score has a high negative predictive value. It's great for ruling out fibrosis. There are some problems with the test. We want to point out the positives and the negatives. It's less sensitive in younger patients, and it's less specific in older patients. So 2 points to keep under consideration. Who should have this test? Anybody with insulin resistance, prediabetes, type 2 diabetes, or overweight patients. Anybody who's got fatty liver identified on a abdominal CT or ultrasound. Anybody who's got high trigs or other components of the metabolic syndrome. Anybody who's got liver function tests elevated. So that's a lot of patients in our practices. And happily, I think the tests, I don't think I've ever had a test not covered by insurance. It's a pretty simple test. You could actually do it yourself in the individual components. So here's our classic photo about how we use the FIB-4 index in risk stratification. And there are many versions of this slide out there, and I like this one the best. So if you have a patient you strongly suspect has fatty liver, and you're going to do a FIB-4 index, if they're a low-risk patient on the FIB-4 index, you would basically going to manage them by your primary care team. And that's another interesting point I should have brought up in a separate slide, but it would really be nice to have a team to handle these patients. I've tried to put things together with local endocrinologists, cardiologists, hepatologists, myself and such, and we haven't gotten very far due to various turf warfare battles and such that I'm sure many of you are familiar with at your institutions. But with the low risk patients, we're really going to focus on obesity management. We're going to assess cardiovascular risk. You could make a case for, making sure you get an ApoB on all these patients, looking at various other imaging studies to screen for subclinical atherosclerosis. It's really, when you identify fatty liver, we're looking at a globally sick patient where there almost certainly has significant insulin resistance. Now, if you get an intermediate risk score, a FIB4 index, you should really think about doing the FibroScan, which we're going to talk about in a few minutes, or the ELF blood test, which is a bit more specific, but a lot more expensive. I haven't been using these. I think I cut out the slide of what it is. It might be coming up, but this is a test that has not been as available to me. So if you get an intermediate risk patient, and according to this algorithm, it says refer to a liver specialist for additional proprietary biomarkers or imaging. I have not been doing that, certainly myself. I think once you become familiar with the strategies of diagnosis and treatment here, you do not need to send these people to a hepatologist. You get high-risk patients with advanced fibrosis, sure, you're going to send them to a hepatologist. There are a number of different drugs and developmental stages for treatment of early fibrosis. That's a minority of your patients, but those are the ones you want to send to a hepatologist. I really think we, as clinicians, as cardiometabolic risk reduction experts, I think we should be the ones treating these intermediate risk patients. And here's the ELF score. As I said, it contains a number of advanced biomarkers like hyaluronic acid, procollagen 3, N-terminal peptide, tissue inhibitor, metalloproteinase. I don't even want to know what these things cost, but it's probably a lot. So like I said, I haven't done this a lot, but it has certain minor advantages over the FIB4 test. But really, FIB4 testing is, I think, the way to go for the majority of us. So let's say you get somebody with an abnormal FIB4 test. What's your next stage? If you got intermediate or higher risk, you're going to go to elastography, which the company that does this most commonly is called FibroScan. And this is easy to do. It's a simple ultrasound. The patient has to be fasting. That's important. So they have to be fasting, or the test is not as accurate. And I really encourage you to develop a local relationship with a GI guy, hepatologist, for fibroscanning. That can be a little difficult because some institutions have not allowed us to send patients for fibroscanning unless it generates a hepatology consult for them, which I know the majority of these patients do not need. I think we can do this ourselves. So just find a place that does fibroscans. We have several of them, and we do at least several a week. I have a telemedicine visit with a patient tomorrow to discuss his highly abnormal results. And so I think that's really the way to do this, is develop a relationship. The test is simple, no radiation. It probably takes 20 to 30 minutes tops. And this is the data that you get from this. One of my live patients, this is the kind of data you get. It's almost incomprehensible when you first look at it. Like, what the heck are all these numbers and images? This is obviously a fax. So what you get are two parameters called the CAP score is the first one. And the CAP score is basically telling you how much steatosis you have. And you can see in a little bullet point that came up, a patient like this with a 335 CAP score, that means over 67% fatty change in the liver. So that's pretty significant fatty liver. This is a guy who's really been struggling for years, has really never made any serious attempts towards exercise or weight loss. I have a feeling he's going to be motivated tomorrow when I talk to him about this high CAP score. Then the other number you get is an index more of liver stiffness. Okay, and that's called the KPA. It's measured in kilopascals. So this is a fibrosis score. This guy's number of 4.8 puts him in a low level of fibrosis. As you can see, he would be an F0 or F1. There's 4 stages of fibrosis. So we've caught him at the right time. He doesn't have fibrosis yet. He doesn't need a hepatology consultation. He needs weight loss. We need to work on all the things we can do to prevent and treat insulin resistance. This is the app. It's called My FibroScan. It's available. I'm an Android Universe person, but I would imagine it's available for those of you that are still stuck with iPhones and haven't upgraded yet to the Android universe. So My FibroScan is a great little app, and what it will do is take that raw data you just saw, you scan in that QR code, and it will turn it into this, which is a really nice looking report. that you can discuss with the patient. I like color-coded reports in my patients. One of the reasons we use Cleveland Heart Lab for all of our advanced lipidology testing is because it's color-coded, and I think it's a great teaching tool. So you can see that this guy is right at the borderline of the S2 to S3 stage for steatosis, but he doesn't have any significant fibrosis. I'm not sure technically what the difference is between F0 and F1, but it's considered to be no fibrosis. Then you go into F2, F3, and F4. So just a really nice report, very easy to upload into your EMR and such and send out to your physicians you're consulting for. So the prevalence of NAFLD, as for those of you who came in late, I prefer the term NAFLD because it emphasizes the metabolic dysfunction here as opposed to the non-alcoholic negative function, saying everything else wastebasket term, but the metabolic dysfunction here. And this article really advocates the more widespread use of FIB-4 index. Interestingly, this FIB-4 index also predicts renal disease, it predicts cardiovascular disease, it predicts mortality. It's a really interesting and little well-known non-invasive test for cardiometabolic risk assessment. And I do it on virtually all my new patients. If someone comes in for clinical lipidology assessment, it doesn't appear to have any red flags for insulin resistance, I probably wouldn't do it, but that's a minority of our patients, as we all know. So the interplay between diabetes and NAFLD is quite apparent. It's a positive feedback loop. The NAFLD promotes worsening insulin resistance, increased risk of atherogenic dyslipidemia, hyper-ApoB states. Diabetes gets worse, insulin resistance gets worse, cardiovascular disease goes up. On the other hand, diabetes obviously promotes NAFLD, and the more poor the control of your diabetes, the greater your risk of cirrhosis, and then the worst potential outcome, hepatocellular carcinoma. So, as we mentioned before, a lot of these patients, most of the patients with steatosis or fibrosis, do not have elevated liver function tests, as you can see here. This was a study where the 70% of patients in an endocrinology clinic with diabetes actually have steatosis, and yet only a minority of them have elevations of the liver function tests. It's a little bit higher in patients who have progressed to fibrosis, but I hope you get the point. Don't think that normal liver function tests rule out NAFLD. That's the point. In the interest of time, I probably won't spend as much time on this as I originally intended, but there's a tremendous interplay between cardiovascular disease and NAFLD. And not being a cardiologist, it's fascinating to me, some of the stuff here on the far right, how NAFLD, through metabolic dysfunction in the mitochondria in the liver, you get decreased ATP generation. Remember, uric acid, when it's elevated, as it is in many of these people, just interferes with the production of ATP, and that is going to lead to is going to lead to heart muscle dysfunction, lipotoxicity, ischemia, diastolic dysfunction, etc. And most of the rest of this you're probably aware of. Certainly, the hyper-ApoB state that we all treat all day is worsened by the presence of NAFLD. One of the great things I learned from Harold Bays early in my term, some of you might remember his coining of the word adiposopathy. We really need to orient our treatment, which we're coming to next, towards repairing the dysfunction of the adipocytes. That's really where it's at in terms of the pivotal driving force behind insulin resistance. So this was really the key article in this whole field. We had Dr. Kuzi, who's the last author here, speak at one of our FNLA meetings a few years ago, and he really drove my interest in this field, and he's great and readily available to contact if you need him. So our nutritional treatment options, I'm going to take a quote from one of my mentors and friends, Dr. Robert Lustig. If anybody's ever heard him, just go to YouTube. I have links to him on my website. I mean, he will just go on and on about the evils of fructose. And here we're not necessarily talking about eating a little bit of fructose and blueberries. We're talking about all the fructose that's in our processed foods. I have a staff member here who just drinks like 2 or 3 regular Dr. Peppers every day. Won't hear anything about diet soft drinks or anything, or drinking water. When you drink fructose, you get such a burst and concentration into your liver that it really promotes insulin resistance. The liver is the only organ that can metabolize fructose, unlike glucose, which can be metabolized in the periphery. Fructose highly toxic to the liver. So I tell my patients, look, public enemy number 1 in the American diet now is fructose. It's not fat. You want to eat some eggs, you want to eat some sausage, whatever. But fructose is really the enemy, and we need to focus on that. And one way of doing that, eliminating fructose, is focusing on a modified Mediterranean diet, a standard Mediterranean diet, but lower in the simple carbohydrates. We really need to drive weight reduction to effectively prevent the progression of fatty liver. Fiber is important, fish, vegetables. You can see some of the nutritional things. We're going to talk about coffee again in a moment. As I said earlier, you can get significant reduction of liver steatosis through even as little as 3% weight loss. You can get reduction in ballooning and inflammation by greater than 5%. You can get NASH resolution of the inflammation if you get greater than 7% weight reduction. But fibrosis requires more. You really need to get at least 10% weight reduction. And all of these weight reduction goals are certainly achievable now through pharmacologic means. Weight management, and a lot of information on this slide. In the interest of time, I'm probably going to skip over it, but basically more weight loss is going to be associated with more resolution of the adiposopathy and of the insulin resistance. We really want to minimize alcohol intake. We'll come to that with a separate slide. But once you get into your intermediate risk patients, the indeterminate risk patients, you really want to begin thinking more and more about the use of a GLP-1 agonist, preferred for NASH patients. And we'll talk about some of that data in a moment. Certainly, there are other weight loss options. We use a lot of phentermine topiramate. I don't know if many of you are, but it's inexpensive, very low dose phentermine is not a problem. It's not fen-phen. We use that combination together and we get pretty good weight loss. It's available generically. You don't have to go with a branded Qsymia, which almost no insurance is covered. But as we get into more and more indeterminate and higher risk patients, we really want to focus on the GLP-1 agonists. So eating patterns, snacking is an independent contributor to NAFLD. There's pretty good data on that. These patients that tell us that they eat 1 meal a day and they still are incredibly obese, and I always wonder what the heck is going on with them. But there's definitely evidence and references here that skipping morning and midday meals increases the odds of steatosis by a huge amount. Now, the counterpoint to that is certainly, time-restricted feeding appears to have some benefit, if nothing else, as a tool for reducing caloric intake and as a way of generating a calorie deficit. That's how you lose weight. You have to generate a calorie defect. I've looked at, as many of you have, many different types of diets down through the years. And although I favor a low carbohydrate approach, I think that's just another hack to really create a caloric deficit. That's what you really need to do. You need to avoid calorie-dense nighttime meals. Grandma was right. You're not going to sleep right, and you're going to promote insulin resistance if you eat after 8 o'clock and you're going to sleep. I'm not eating anything more the rest of today. This is, many of you know Pam Taub, who's lectured with us before. Pam has some great stuff out there about time-restricted eating in adults. And I've come to the conclusion that there's really nothing magical about the amount of time restriction itself. It's really probably more just of a hack for reducing caloric intake. The jury's still out on this a little bit. There was a somewhat controversial trial that came out last fall, which really wasn't a good test of time-restricted feeding. But I use this concept a lot with my patients. And the way I use it is trying to get people to eat lunch and dinner, nothing before, nothing after. Really, really simple. And I have found that to be highly effective in promoting both weight loss and improved insulin sensitivity. No alcohol. I enjoy, as some of you know, a good glass of Oregon Pinot or single malt Scotch as much as anybody, but I am more and more afraid of the effects of alcohol as more and more data comes out. alcohol is a neurotoxin to the brain. There's just no doubt about it. Every drink is bringing you closer to a dementia one day, is the way I put it to patients. And the alcohol really has to be, completely abstained with anybody who's into the intermediate or more advanced stages of NAFLD. And I tell patients, even in the early stages, look, you really need to cut this down to 1 or 2 drinks a week maximum. Coffee, on the other hand, lots and lots of positive benefits, tons of good stuff coming out about coffee lately, a 40 to 80% reduction in cirrhosis-related hospitalizations and death. And here we're talking about, obviously, moderate intake, not drinking whole pots of coffee a day, as some people do, unfortunately. But each additional cup of coffee per day decreases the odds of advanced fibrosis by 36%. So you really want to consider 2 to 3 8-ounce servings of regular brewed coffee every day. You want to try to keep that total caffeine intake down to less than 400 milligrams. I forget how much is in a cup of coffee, but that sounds about right, the number of servings. Now, if you're going to Starbucks and getting the super potent stuff, you may have to not do that, or get something a little less potent on the caffeine level. And certainly you can ruin the whole thing, the benefit, by adding a lot of sugar and a lot of fat to your coffee. Exercise. Okay, exercise produces, without any weight loss, produces a 20 to 30% relative reduction in steatosis. And all forms of exercise seem to be beneficial. As I said before, one of my big things I try to promote in patients, and hopefully in CELA, is that you need to do resistance training. All the recommendations say a minimum of 30 minutes, 2 30-minute sessions per week. And I certainly got mine in this morning at my favorite place, Planet Fitness, right down the street. I have pictures all over my office of me exercising, kayaking, lifting weights, doing all kinds of things. Those of you who are into exercise, and I hope most of us are, there's a great podcast called The Docs Who Lift, DOCS, Docs Who Lift. It's free and it's just fantastic. And one of the guys, both of them are Polish, which is great. And one of them is a board certified clinical lipidologist. So they're very, very interesting to listen to for patients and professionally, and they're quite entertaining also. So again, we're aiming for 150 minutes per week of moderate physical activity. Sarcopenia, as our patients get older, we don't have time for this tonight, but there's a whole series of papers written about sarcopenic patients with fatty liver. So this certainly can happen. We're, in many cases, in many ways, a protein deficient nation, and many of us are getting sarcopenia as we get older because we're not doing resistance training. You want to prevent that fall when you're 80. And if you do fall, you want to be able to get back up. So to do that, you're going to need to do resistance training. Now, what about the safety of statins in these patients? So these are patients in a pioglitazone trial, which we'll come to in a minute. But you can see the liver function tests going down very nicely when you add a statin to the regimen. So there had been, one of the most frequent reasons I get a consult is somebody has elevated liver function tests, and the referring doc wants to know if it's okay to use a statin. Well, as we know, if we have an explained reason for the elevated liver function test, such as fatty liver, NASH, et cetera, NAFLD, it certainly is safe to use a statin. As a matter of fact, statins do a lot of positive things. Again, in the interest of time, we're not going to go through all of this, but I was astonished to see the statins actually seem to retard the progression of fibrosis in the liver. They reduce inflammation, they reduce portal hypertension. There's some evidence that they may even help prevent hepatocarcinogenesis. They seem to reduce the steatosis itself. So, dare I say it, statins are almost a first-line treatment for NAFLD. And since most of these patients also have elevated ApoB and increased cardiovascular risk, do not be afraid to use statins. And matter of fact, I would say this is a reason to pull out a statin in a patient where the patient may not want to take a statin, or you may question whether they need a statin. If they have significant NAFLD, I'd say forge ahead with your statin therapy. We talked earlier about the triangular risk reduction of cardiometabolic risk reduction in diabetes. We're trying to reduce NAFLD. We're trying to reduce cardiovascular disease. We're trying to reduce nephropathy. Diabetes management, again, or not again, but metformin, although is a wonder drug in diabetes, and I'm not just talking about glycemic control, I'm talking about some of the many other things the metformin does for diabetics. It seems to reduce, there's some evidence, weak though it is, that it reduces cardiovascular events, but it looks like it improves longevity, reduces Alzheimer's, reduces cancer in diabetics. So I have all my diabetics on metformin if they can tolerate it. But once we get into NAFLD, we're really going to start going more with the GLP-1 agonists. So pioglitazone, until I ran into another one of my heroes and mentors, Dr. Ralph DeFranzo, until I ran into him and started lecturing with him, I really had not used pioglitazone much, but pioglitazone is a wonder drug for NAFLD. Now, the patients get upset because they get a little bit of weight gain on pioglitazone, but what's happening is their visceral fat, the bioactive fat that promotes insulin resistance, that's actually shrinking. The sub-Q fat is getting a little bigger, and sometimes they retain a little fluid. So people can gain, 1 or 2% body weight on pioglitazone, but it's a wonder drug in its effects on insulin resistance and on NAFLD. It mediates the histologic effects of NASH. It's a drug we should all be using every day. It's cheap. It's got cardiovascular event reduction data. The only real thing you have to worry about with pioglitazone is don't use it in someone with significant heart failure. And we probably all had a patient or two, we put them on pioglitazone and they wound up in the ER in heart failure. I know I have. And these were patients I didn't know had heart failure at all. They had probably significant diabetic diastolic dysfunction. So, what do we get when we put a patient on a PPAR alpha agonist like pioglitazone? Well, we get a little bit of weight gain, but we get dramatic improvement in parameters of insulin resistance. We get improvement in diabetic control, and we get reduction in cardiometabolic risk, both in the test tube and in patients. So some of you may remember pioglitazone has cardiovascular event reduction. So it's a drug we all ought to be using. Often I use it in metformin, even in some of my pre-diabetics. Here's the weight change in one study with pioglitazone. It was pretty minimal weight gain in diabetics. You can see we're talking 1%, 2%, et cetera. And how do you mitigate this weight gain? Well, you can use it with a GLP-1 agonist, as they did in SUSTAIN 2 with semaglutide. You can use it with oral semaglutide if you have that patient who absolutely does not want to have an injection, and you can combine it with an SGLT2 inhibitor, which I do a lot, more specifically in my patients who don't need a lot of weight loss. What about semaglutide itself? Well, it has amazing effects, most of which are probably due to the weight loss, but there are other weight independent effects. But you can see, pretty dramatic resolution of steatohepatitis and no worsening in liver fibrosis. I'm using even small doses of semaglutide. So this class of drug is really becoming obviously our number one drug for weight loss and also for treatment of NAFLD pharmacologically. Tirzepatide, the newest kid on the block, also shows significant reduction in liver fat content, visceral adiposity, et cetera. This is in a small Eli Lilly study. Obviously, it's not indicated for this yet, but results are very promising so far with this newer agent. How do you get your patient a GLP-1 agonist? Well, insurance coverage is lousy. I'm not sure if you guys, I assume you guys can still see me, but here's my latest rejection for semaglutide for weight loss. Just came in a while ago. We had hoped that we were going to get some better coverage this year, but so far that doesn't seem to happen. I'm a real stickler, and I'll probably cause some gasps here, but I do all of my own prior authorizations. My staff can do some of the simpler ones, like maybe the PCSK9 inhibitor re-renewals, where it just says, is the patient on the drug, no further questions. But we should be doing this ourselves, and I probably spend at least a half hour to an hour a day doing my own prior authorizations. But the success rate's going to be better, because we're the only ones that really know exactly what's going on with the patient in terms of their pathophysiology. We want to use cardiovascular risk reduction codes. We want to fight for our patients. We appeal most denials. We've had very bad success with trying to get semaglutide approved for weight loss. we've had very poor success with Wegovy coverage, and that was theoretically going to change as of the first of the year. I haven't noticed anything yet, so we'll see if anybody has anything to say in the discussion. Might this be better covered? I don't know. I'm personally very upset with Eli Lilly and all the broken promises that were made about tirzepatide availability. That's a whole nother rant maybe, but it should be approved for weight loss later this year if the clinical trial works out. And some of us have even taken to getting semaglutide ourselves and selling it to patients at cost. There are clinics popping up all over the place, and I think that's certainly something that particularly those of us that run small independent practices where we can do whatever we want as long as it's ethical and legal, we can certainly do this kind of thing, and it's popping up everywhere. Just do a Google search for your own zip code and semaglutide, and I guarantee you'll find somebody you could walk to probably who's doing it. There are many drugs under development for treatment of NAFLD. This is one of the latest ones that came out late in the fall, where it looked very promising. This is a messenger RNA targeted therapy. So we have a number of these things going to come out over the next few years, and they're mostly going to be for people with advanced fibrosis. So this is the reason why you want to get those patients to a hepatologist, those with advanced fibrosis levels F3 and F4, because they may have access to get into clinical trials. I have a couple patients in these trials. So back to our original patient, and we'll finish up. So what are we going to do with this patient? Well, we're managing her, outside of the liver clinic. Looks like she's got NASH and advanced fibrosis. We're going to put her on a statin. We're going to optimize her glycemic control. We're going to think about pioglitazone and metformin for NASH, as it's been called. We're going to think about semaglutide. We've got other drugs under development. This is what happened with her. So her FibroScan was suggestive of advanced fibrosis. So she got a liver biopsy, very appropriate to send her to a hepatologist. She was prescribed lifestyle changes, semaglutide, pioglitazone, which can be used together. Rosuvastatin has been titrated up. She's seeing a nutritionist, and I apologize, I hadn't mentioned nutritionists yet, but all of our patients in the lipid clinic are seen by a nutritionist at one time or the other, and we particularly focus on long-term management with a nutritionist for the patients with insulin resistance. You can see her liver function tests went down, fasting glucose went down, or A1C went down. Or LDL cholesterol is pretty well controlled. I certainly would want to get an ApoB in this kind of patient because of the discordant effects between LDL-C and ApoB. Trigs are down, I think, from what we originally saw, et cetera. So as we already mentioned, when we're going to refer to hepatology, particularly advanced fibrosis patients, that would be the main thing. The hepatologists do not want to see, routine consults where my liver tests are elevated. What do I do? We can do that ourselves. If you've got concern for Wilson's disease or mixed etiologies, or you see hepatic mass on imaging studies, then you're going to refer. I think we've been through most of this. Metformin is not as effective as some of the other drugs. We mentioned pioglitazone. Bariatric surgery has amazing effects for these patients. Here it is. Here's my dietitian slide. Use your dietitians. I do a lot of CGM with my patients at $70 a month. We always use Freestyle Libre because it's much less expensive and I think better for patients, and particularly the Libre 3 now has a better real-time assessment of glucose. You don't have to manually read it as much, but we encourage our patients to get these things for $70 a month, to do it even for a month, to look at your level of insulin resistance. We talked about statins being safe, and there are a number of organizations out there. This is one of my favorite ones. I got some of these slides from them. So I have no idea what time it is. Okay, good. It's about 14 of. So let me maybe open this back up. Kathy, maybe we can open this up for questions. I haven't been able to pay attention to the chat because I'm not a good multitasker or anything, but let's open it up. Kathy, if you can hear me, maybe we can take some questions and also talk about what we want to do for future SEAL nights. Kathy, yeah, okay. Well, look at all these wonderful people. No, I'm not hearing anything. Anybody got any questions? I see a bunch of people, but I'm not hearing anything.
Hey, Greg, it's Jan.
Hi, Jan. Great.
Hey, first of all, I just wanted to clarify, Alyssa Nance is actually the one who came up with CELA Speaks. It was not me.
Okay.
So I want to give credit where credit is due. So thank you very much, Alyssa, for the suggestion of CELA Speaks. We really like the way it sounds. Second thing is, Greg, great job. A lot of very useful information.
Thanks.
It's interesting because I have actually formed a partnership with my liver transplant center because I'm a part of a huge organization. And so they want me for the statin use, diet, and medication, and I can pretty much easily get my patients in to see them when needed. Unfortunately, I can't order the test since I have such a big liver transplant. But one conversation that I have with individuals to really stimulate them to want to do as much as they can to manage their disease is talk about, fatty liver disease is the #1 diagnosis for liver transplant in the nation. And patients don't realize that. They think, oh, I just got fatty liver, and that's no big deal. So I appreciate all your information on the topic. You did a great job.
Hey, thanks a lot, Jan. I got some questions in the chat. Maybe let's get into a few of them. And the first one is to give Alyssa credit. And then Tom White gave us a better email. That's in the chat. If anybody wants to work with Tom on any of these projects. Let's see what else here. Let's see. Here's Shannon. Kristen is talking about meeting with the Wegovy rep and have been getting samples. And they are saying they're starting people on the starting dose of Wegovy based on samples and then ordering the 0.5. So that gives the patient sort of a 1 month head start. And certainly we have tried to do the same. We have some Wegovy in our refrigerator also, but it seems like the reps are providing less and less. I know my Ozempic guy came by today. Just gave me like 2 starter kits. He used to give me a lot more in the past. So that's why I mentioned we may have to get creative with some of these things. And those particularly who have smaller independent practices and can do, again, what we want, as long as it's ethical and legal, I would encourage you to look into the possibility of getting your own semaglutide and just doing an end around the system. That's what we're starting to do. Can we get a copy of the slides, Alyssa? And I've been told by Kathy that is going to happen. It doesn't happen quickly, but I really wanted this to be a resource for people. And a lot of these slides are from other NLA lectures and from the literature. A lot of them I got myself, some are from Quest and such. So yeah, I think it'd be a good resource and teaching tool. They're using the FiberSure blood test. Someone has said, Jason Hino said this, and I don't know. I honestly don't know what that is. So maybe somebody can. So here's a great challenge. I would say a lot of you who are on Facebook, why don't you join the CELA Facebook page and get in there? And Jason Hino, sorry, I don't know you, but why don't you, if you're willing to do that, why don't you look into this and enlighten us as to what the FiberSure test is, and maybe we can drive some discussion to that platform. I don't know of any other great platform where we could discuss stuff like this. So why don't we do that? So Jason, if you're hearing me, are you up for the challenge? You may not be able to unmute yourself, Jason, but I hope you're hearing me. So if not, I will do it. Let's see. Romara Godsai said it was a great talk. Any role for vitamin E? I skipped over that a little bit in the interest of time, but it's interesting that the hepatologists I talk to don't seem very excited about vitamin E, but there is, data in the literature that I think it's 800 units per day. There are some small older studies that seem to show some benefit. Now, from a cardiovascular standpoint, I was always a little leery of vitamin E. Some people had hypothesized it may interfere with HDL functionality and such. So I've never really used a lot of vitamin E, but it is recommended in a lot of these review articles, 800 international units per day. And remember, since it's a fat soluble vitamin, I would give it with food. You're going to get better absorption, just like we get with vitamin D. Daniel Esau says, is there any difference in how the patients lose weight, diet and exercise versus medications? And I would say, from my review of the literature, that the amount and magnitude of weight loss is the most important thing. Now, there's probably emerging evidence that semaglutide may add a little bit to that through some of its positive effects on histology in the liver and the inflammatory aspect of things. But the most important thing is weight loss, and a low fructose diet, since fructose is so toxic to the liver. I'm wondering if studies have been looking at fat reduction with something like Ozempic or newer diabetic meds. Yeah, so all these studies are emerging. Every medicine you could think of, SGLT2 inhibitors, GLP-1s, tirzepatide, they're all doing studies in NAFLD. So we're going to see a lot of data coming out. There's Jan had mentioned there's currently a national shortage of Ozempic. Well, we've seen a shortage of Trulicity here, and we've been switching patients to Ozempic. So I don't want to hear this, Jan, but if it's true, I understand. Our Ozempic guy seemed a little leery today when he came in, so we'll see. Jason said he's not on Facebook anymore, so he can't do that. So maybe I'll look into that. It was called the FibroSure, and I'll see what I can find out about that. I would be surprised if it's the same thing or somebody else's proprietary similar test. As a cardiologist, I used to say 2 glasses of wine is okay. Who's saying that? Avinash Gupta. But I'm saying no alcohol is good. I tell you what, if any of you listen to my buddy Dr. Huberman on his podcast, he's a famous neurobiologist. He has a 2-hour discussion of why alcohol is bad for you. And it might sound like a dry topic, but he's actually quite entertaining. And I would challenge you to listen to that. Look up David Huberman podcast. It's called Huberman Lab, I think, is this podcast. And he's friends with people many of us know, like Dr. Peter Attia and various other leading medical podcasters. But alcohol is a neurotoxin. I mean, there's no doubt about it. All this earlier data that seemed to show a cardioprotective effect, as far as I know, none of that has stood the test of time. We know from the Million Women study in Britain that you double your risk of breast cancer from 1 glass of wine per day. Ladies, 1 glass of wine per day. I don't like those odds. And then gastrointestinal cancers certainly go up. So, I tell patients, look, don't ever drink thinking you're doing yourself any good. Drink because you want to have a single malt scotch once in a while or whatever, but do not drink every day, and do not think you're doing yourself any good. That's, I think, the 2023 opinion of alcohol. Would a diagnosis of NAFLD help with insurance approval of GLP-1s for weight loss? I've thought of that, and I haven't done it a lot, but I should, and I really should. I'm almost given up here on trying to get prior authorization approval for Wegovy after we've had so many failures. I mean, maybe things will change, but I think that's a great strategy. So I think it would be great to add NAFLD in there. But remember, the GLP-1s aren't FDA indicated for NAFLD. So I don't know if insurance companies are going to factor that into their equation, once we get an official indication, maybe. If you start a statin on NASH or NAFLD, how soon can you expect to see the reduction in LFTs? I did show that slide, and it was over a period of a few months. I always tell patients, look, anybody that start on the statin, your LFTs might bump up a little. I tell patients that, this is the statin kind of shaking things loose in your liver, getting rid of some of the fat, and there's a little inflammation on the way out, and then things are going to come down. But you could see it was within a few months that things got better. And thank you for your kind words. Dr. Gupta said we ought to have more talks, like this, maybe focused on cardiometabolic disease. During my year, I'd love to see things focused on cardiometabolic disease. So we now have 4 minutes left. I'm not sure if that's a hard stop, Kathy. I wouldn't be surprised. Kathy's pretty tough, so I'm guessing that's 2.5 minutes now. I don't know, but does anybody have any thoughts about what subjects we want to hear in the future? So somebody just suggested a talk on low HDL, Dr. Gupta again. Yeah, hi.
Yeah, hi.
You know who we should get to do that? Well, I don't know if I guess we should have a SEALA member, but I always think of Tom Dayspring, my mentor, hero, and just a great talker. He talked even faster than me. So that would be a possibility. I don't know. If we have other board members here or people want to contribute, we can get some topics. Tom would be the first person that comes to my mind, unless a SEALA member wants to do it. And then somebody said low LDL talk. Boy, very interesting. Is that correct, Miss Ruth Gibson? Did I reading about you want to talk on low LDL? Wow. Okay. Low LDL. Okay. So we got some topics that Jan and I and the board can Chris Colts here is saying Tom Dayspring. Okay, we got at least one vote for Tom. Some of our younger members may not remember him, but he's the first NLA President's Award member, and I would bet you that half the people in the NLA right now are here because either a first or second degree relationship to Tom at a lecture or somewhere else. So that would be fun. So we're hearing seconds and thirds for Tom. So I am going to call my buddy on the way home tonight and see what he says. I don't know if he's here. I didn't see. Tom's technically, he is in SEALA now. I didn't see if he's here or not. Tom, if you're here, please say something. So let's do it. We're about to be cut off. Looks like we got a minute and a half left before Kathy gives us a hook. Anybody got anything else for topics or anything else? Coronary calcium score, we could certainly get Seth Martin or one of the guys from Hopkins to talk about that. Kathy Byrne, if you're here, she would be our intermediary there. Oh boy, carotid IMT. Oh boy, one of my favorite topics. We're doing something that's a lot better than carotid IMT, and Tom Barringer, former SEALA president, would be the guy to talk about that. And I think I could convince him to do that, Jan and other board members. LP(a), fantastic topic. Not exactly. Tom could potentially do that too. Tom loves talking about LP(a), so he's another person. And Mike Blaha, yes, as Vicky said, would be the guy to talk about calcium score. So, all right. Well, I think it's about time to wrap it up. I'm sorry I did all the talking or a lot of it. When you prepare one of these talks the first time, it's always turns out to be longer than. But it sounds like everybody stayed interested and is still here. So I appreciate the opportunity and look forward to doing this again, maybe in a month and a half or whatever we can put it together. Hopefully this time works for people. Oh, lean body. What was that? Lean body hyper responders. That's your people on ketogenic diets, perhaps, to get. Yeah. So we got some topics here, SEALA board. Maybe Jan, if you think of it, why don't we get a round robin discussion going with SEALA board members about how we can implement some of this stuff, and we'll bring it back to the people again. Thanks a lot, everybody.
Expect emails from me. We'll start the conversation.
Sounds great, Jan. Thanks a lot, everybody. Good night. Happy New Year, and see you next time. Thanks.